What if the pill your doctor prescribed to protect your heart has quietly been stealing your energy, adding pounds to your frame, and pushing you closer to diabetes? All while you blamed yourself for simply getting old. That is not a hypothetical. That is happening right now to tens of millions of people, and almost none of them know it. Stay with me because what you are about to hear could genuinely change the trajectory of your health. My name is Dr. Joseph. I have spent over 2 decades as a cardiac surgeon, and I have had a front row seat to one of the most important conversations in modern medicine. Today I want to give you the honest, unfiltered version of that conversation. The kind most doctors simply do not have time to have. Beta blockers have been around since 1964, the very first one. Propranolol was genuinely revolutionary when it arrived. Doctors were excited and they had every reason to be. Through the 70s and 80s, beta blockers became the automatic first choice for high blood pressure. A patient walked in with hypertension and a beta blocker was on the prescription pad before they even sat down. It felt safe. It felt proven. The problem is that medicine has learned an enormous amount since 1964, when stress or physical activity triggers your body to release adrenaline. Those switches flip and your heart rate surges. Beta blockers sit on those switches and prevent adrenaline from activating them. The heart beats slower. Pumps with less force and blood pressure drops. Logical, clean, effective for certain patients. But here is where it gets complicated. When you are 60, 65, 70 years old, your cardiovascular system already operates very differently than it did at 40. Your resting heart rate is naturally lower, your blood vessels are less flexible. Your kidneys process medication far more slowly. A drug that behaves perfectly in a 45-year-old body can behave very differently, and sometimes harmfully in a 68-year-old body. Then in 2005, a landmark study called the ASCOT trial changed everything. Researchers compared beta blockers directly against a newer class of drugs, called calcium channel blockers in a large group of hypertension patients. The results were so striking that the trial was stopped before it was scheduled to finish. Patients on calcium channel blockers had significantly fewer strokes, fewer heart attacks, and a substantially lower risk of developing diabetes. The beta blocker group did not just perform worse, they lost by such a margin that continuing the comparison felt ethically unjustifiable. After ASCOT, major medical organizations began quietly revising their guidelines. Britain moved beta blockers off the first-line list for uncomplicated high blood pressure. European guidelines followed. American guidelines became significantly more cautious. But here is the critical gap that concerns me deeply. Guidelines change in journals and textbooks. They do not automatically change what is already written on your prescription. That renewal gets processed. Nobody reviews it. Millions of patients started on these drugs 5, 10, 15 years ago are still taking them without a single person asking whether it still makes sense. Now let me tell you what I hear almost every single time a patient over 60 comes to me after years on a beta blocker for blood pressure. They say the same thing without fail. I just thought I was getting old. And here is exactly why that happens. Beta blockers slow your heart rate by design. A slower heart pumps less blood per minute, which means less oxygen reaching your working muscles. When you try to climb stairs, carry groceries, or walk to the mailbox, your heart is physically prevented from responding the way your muscles are demanding. You press the accelerator and nothing happens. And when older adults feel that exhaustion, they naturally stop moving. They sit more. They walk less. They give up activities they used to enjoy. Reduced physical activity is one of the most powerful accelerators of cardiovascular decline we know of. Then there is the diabetes risk, which almost never comes up in routine appointments. Studies show beta blockers, particularly older ones like atenolol, are associated with approximately a 22% increased risk of developing type 2 diabetes compared to patients on alternative medications. Nearly 1 in 4 additional patients developing a serious lifelong disease from a drug they took specifically to protect their cardiovascular system. The mechanism is well understood. Beta blockers interfere with insulin release from the pancreas, reduce insulin sensitivity in muscle tissue. Year after year, they are nudging your metabolic profile in exactly the wrong direction. There is also the fall risk, which is critically underappreciated. When you stand up quickly, your body normally compensates in an instant. Heart rate ticks up, blood vessels tighten, blood pressure holds steady. On a beta blocker, that response is blunted. Blood pressure drops for a few dangerous seconds. In adults over 65, that is one of the leading triggers of serious falls. And a hip fracture in someone over 65 carries up to a 30% mortality rate within 12 months, not from the fracture itself, but from the cascade of complications. Now, and I cannot stress this enough, do not stop taking your beta blocker on your own. Not tomorrow morning. Not after finishing this video. Your body has physically adapted to this medication over months or years. Stopping suddenly can cause a dangerous rebound, heart rate spikes, blood pressure surges, and in some patients, a serious cardiac event. Coming off a beta blocker safely requires a gradual, medically supervised taper with careful monitoring throughout. There are also patients for whom beta blockers are absolutely the right medication, those with coronary artery disease, survivors of a heart attack, patients with heart failure or certain arrhythmias. For those individuals, these drugs are life-saving and should not be touched without a very carefully justified medical reason. But if you are over 60, taking a beta blocker purely for blood pressure, with no history of heart attack, heart failure, or arrhythmia, it is completely reasonable to sit with your doctor and ask directly, given my current health and today's evidence, is this still the best option for me? Write that question down. Bring it to your next appointment. Hand it to your doctor if you need to. That single question could be the most important health action you take this entire year. Medicine is not static, and the best patients help their doctors keep up with it. This is the channel where we give you the knowledge to advocate for your own health. If this opened your eyes, then do me a favor, subscribe my channel, and share it with someone who needs to hear it. Your heart is worth the conversation.